I start in the name of Allah, the Lord of Mercy, the Giver of Mercy. I'm Dr. Awan. I'm the consultant physician and currently working in UK. In this presentation, I'll discuss 3 short cases which you may encounter in your exams as OSCE, TOACS, or whatever the local name is given to these exams, or in your real life practice. These short cases are related to the motor system examination. The first one is upper motor neuron lesion versus lower motor neuron lesion. Second one is about the spasticity and rigidity. And third one is regarding internuclear ophthalmoplegia. So we'll start with the first one, upper motor neuron versus lower motor neuron lesion. So when you are asked to examine the motor system, so you start with inspection. I'm not going into the details of examination of the motor system, but just briefly, the inspection, the check for the muscle tone, and then the muscle power, then you check the tendon reflexes, and then the plantar reflexes, and then you go for the superficial reflexes. So depending upon the findings on this examination, you need to decide whether there is an upper motor neuron lesion or lower motor neuron lesion. And that way, whether the upper motor neuron versus lower motor neuron, you can localize the lesion in the brain or the peripheral nervous system. So if you recall your anatomy, which we have already discussed in the previous lecture as well. So upper motor neuron usually starts with the precentral gyrus. The neurons are located here. The precentral gyrus is called the motor cortex as well. And this is the motor cortex. So from neurons, the axons from these neurons go down through these tracks to the posterior limb of the internal capsule, through the midbrain, through the pons, and the medulla, and most of the fibers decussate to the opposite side. And most of these fibers decussate to the opposite side, and some fibers continue going down in the same on the same side as the corticospinal tract, lateral corticospinal tract, and anterior corticospinal tract. So starting from the starting from the motor cortex down to the anterior horn cell, this tract is called the upper motor neuron. And from anterior horn cells to the roots to the peripheral nerve to the muscle. So anterior horn cells to the muscle through the peripheral nerve. This is the lower motor neuron. The lower motor neurons are located in the anterior horns, and the nerve axon go to the peripheral nerve to the muscle, and these are the lower motor neurons. While the upper motor neurons are located from the precentral gyrus down to the anterior horn cell. The difference between the lesion of these two types of neurons are that we check. So in upper motor neuron, there is weakness, but no wasting. When you examine inspection, you will not find any wasting in upper motor. The patient will present with the weakness of the one arm or the leg, but there is no wasting. While in the lower motor neuron, there will be wasting of in addition to the weakness. The wasting may be in the small muscles or in the bigger muscles. So the weakness with wasting is the lower motor neuron. Weakness without wasting is upper motor neuron lesion. Tone is increased in the upper motor neuron, while decrease in the lower motor neuron. And the lower motor neuron, the muscular movements are quite flaccid and easy to go, but in upper motor neuron, there will be increased tone in certain group of muscles we'll discuss in subsequent slides. Reflexes are exaggerated. You check for the tendon reflexes, the brachioradialis, the bicep, the triceps, and the knee and the ankle. So reflexes are exaggerated in the upper motor neuron lesion, but are depressed or absent in lower motor neuron lesion. The plantars are upgoing. You check for the plantars of Babinski. So these are upgoing in upper motor neuron and downgoing in the lower motor neuron. And superficial reflexes, the cremasteric reflexes, abdominal reflexes, these are present in upper motor neuron, but are absent in lower motor neuron. So that means that if there is weakness and the wasting, tone is decreased, reflexes are depressed, plantars are downgoing, and the superficial reflexes are absent. This is lower motor neuron lesion. That means the lesion is from the anterior horn cell to the muscles or end organ. So in the upper motor neuron, there's weakness but no wasting, tone is increased, reflexes are exaggerated, and the plantars are upgoing, and the superficial reflexes are present. If these findings, so I mean upper motor neuron lesion, and the lesion is from the anterior, from the cerebral cortex, so premotor gyrus, throughout the pyramidal tract to the anterior onset and corticospinal tract and anterior and lateral corticospinal tract, throughout this tract, anywhere through those. So we have already discussed the localization throughout in the different parts of the brain and the motor cortex. But that is mean upper motor neural signs mean lesion from the precentral gyrus to the anterior horn cell, anywhere from this area. And lower motor neuron lesion mean from anterior horn cells to the muscles. And these are the signs which will differentiate between upper motor neuron and lower motor neuron lesions. Right. The next short case is the spasticity versus rigidity. So when you examine the motor system, you find that tone is increased, right? The tone is increased in some group of the muscles. So that could be either the spasticity or rigidity. So a clinical examination inspection, you look for the weakness and the wasting. The next is to check for the tone. And the tone is increased in the limbs, either upper limb, lower limb, or all the limbs, or right-sided tone, right arm the right leg or left arm the left leg. So we need to differentiate. The examiner will ask you, you tell the examiner that probably the tone is increased in right upper and lower limb or left upper or lower limb. And the examiner will ask you, is it spasticity or rigidity? The difference between spasticity and rigidity is that in spasticity is a pyramidal tract lesion. That means in spasticity, tone is increased in the flexors in the upper limb and extensors in the lower limb. So you must have seen patient with hemiplegia walking with the arm flexed like this and the legs circumducting, just moving this half circle, and that is circumduction. So that means the tone is increased in the flexors in the upper limb and extensors in the lower limb. This is spasticity, and this is a sign of pyramidal tract lesion or upper motor neuron lesion or pyramidal tract lesion. Versus rigidity is the sign of extrapyramidal tract lesion. The extrapyramidal tract means the basal ganglia, which is the basal ganglia here, and here the fiber go down to the muscles. So the extrapyramidal system, the lesion of the basal ganglia or extrapyramidal system, the tone is increased in all group of muscles, in arm, in the leg, mostly maybe in all the limbs, but it maybe localized to one side, but it's asymmetrical, but present in most of the limb or either one upper or lower limb. So in that, the tone is increased in all group of muscles, both flexor and extensor, arm and legs. So it may be asymmetrical. So when you move the arm, it's rigid, stiff all over. And that is spasticity. And this is a sign of extrapyramidal tract lesion. And this spasticity of two types, rigidity. This is rigidity. The rigidity is sign of extrapyramidal tract lesion, and the tone is increased in all group of muscles. So rigidity of two types. There is lead pipe when it is present in all the range of movement, and or it is cogwheel when there are jerky movements when you are checking for the rigidity and tone, and now that this is cogwheel rigidity, and they when usually the tone is increased tone is superimposed on by the tremors, which may not be visible clinically. So extrapyramidal system lesion, so this is rigidity versus spasticity, that means tone is increased in all group of muscle in extrapyramidal lesion, but in spasticity or upper motor neuron lesion, the tone is increased in the flexors in the upper arm and extensors in the lower limb. The cogwheel are led by the two types of rigidity. The cogwheel, they're jerky movements while you're checking for the tone. Lead pipe, where the tone is increased in all ranges of movement. The tremor may be visible or the subclinical tremor. Akinesia or hypokinesia means the weakness in the muscle in initiating the movements. There's are absent weak movements. That's akinesia, and this is the sign of basal ganglia lesion. So the pyramidal tract lesion from central gyrus to anterior horn cells, the extrapyramidal lesion is the basal ganglia lesion. So that is the difference between rigidity and spasticity. Third short case is internuclear ophthalmoplegia. So when this is, when you ask the patient to move the eye toward one side, there is weakness of the abduction. Patient cannot adduct the other eye, and there's nystagmus in the other eye. So failure, medial rectus weakness on one eye and nystagmus in the other eye. So this is, we are looking for, checking for the extraocular movements, and you ask the patient the lateral movements. So one eye is moving laterally, but it's showing nystagmus. The other eye is not moving beyond the midline. So this is the lesion at the medial longitudinal fasciculus. This I'll show you in the next picture what a medial longitudinal fasciculus, which connects with the third and the sixth nerve nuclei. And this is when the patient asked them to accommodate, with the accommodation, eye movements are normal. So if this sign, internuclear ophthalmoplegia, is present in a young, think of multiple sclerosis. And if the present patient is older, think of lacunar stroke. So young multiple sclerosis, old lacunar stroke, that may be the short case. So when the examiner asks you, examine the eye, examine the extraocular movement, eye movements, and when you're examining eye movements, the lateral movements, medial movement, upper, lower, and do you find one eye is abducting, but the other eye failed to abduct properly. So that is internuclear ophthalmoplegia. So this eye is moving laterally, and this is showing nystagmus, but this eye is not moving beyond the midline. When this one moving laterally, this is expected to be moving adducted properly. So this is the sixth nerve and the third nerve. This is the center for the internal gaze. So this is lesion of the right medial longitudinal fasciculus, which connect these two. So this is called internuclear ophthalmoplegia, and this sign, if it's present in a young patient, this is a sign of multiple sclerosis. If the patient is older, it is a lacunar stroke. Right. This is again another picture that's baseline, and these are the normal side, but this side is not. This side is moving the right. This is not moving toward the middle side. Right. Thank you. And the learning from today, the no substitute to clinical examination. You can get these short cases in your examination, and hope this video will be useful for your some of the short cases. Well, thank you very much for watching, and the next video will come with some more short cases. Thank you so much.